In this lecture, we'll discuss the remaining disorders in this class. These disorders fall under the categories of addictive disorders, which will include drug and alcohol use, as well as pathological gambling, cognitive disorders, and sleep disorders. We'll first start out with discussing cognitive disorders, which include disorders where one's ability to process thoughts, hold on to memories, and pay attention is impaired. There are two major disorders that we'll discuss here: delirium and major neurocognitive disorder. Major neurocognitive disorder used to be called dementia, so we'll also discuss Alzheimer's disease as a type of major neurocognitive disorder. Delirium occurs when someone experiences a rapid change in their attention and awareness. Generally, people display symptoms of disorientation for their environment, like not seeming to know where they are exactly or what point in time it is, such as not being able to know the correct date or even year. They may appear confused and disoriented, and they have difficulty sustaining their attention in even simple tasks. For example, they may repeat questions several times because they can't sustain their attention long enough to remember the answer. They also must show impairments in at least one other area of cognition. They tend to show impairments in their memory, not being able to remember things from their past or form new memories. And they sometimes have impairments in their language, such as not being able to recall the word they want to use. But they may also have problems in their visuospatial ability, such as not being able to navigate to a place they are familiar with, or in their perception, including potentially experiencing hallucinations. Importantly, delirium comes on rapidly, not gradually, and symptoms also are likely to fluctuate over the course of the day, such that at some points these impairments may be very minor or barely noticeable, and at other times of the day they are really severe. Delirium may occur in response to some medical condition or in response to surgery or a medication change. It could also be in response to substance intoxication or withdrawal. Alcohol withdrawal can result in a severe form of delirium. With few exceptions, such as brain injury-induced delirium, symptoms will be totally reversible. It is important to figure out what the underlying cause of the delirium is so that it can be addressed, which will result in the delirium symptoms remitting. For instance, if the symptoms were in response to a medication change, symptoms should subside if the person is taken off of that medication. In terms of treatment, medication like antipsychotics and benzodiazepines may be prescribed. Antipsychotics will help with hallucinations or other psychotic symptoms. Benzodiazepines will help calm the person down if they are agitated or distressed. People with delirium tend to respond well to family support and the use of orienting techniques, such as showing the person a calendar so that they know what the date is, or having them look at a lot of family pictures to help them remember their family. It is important for the family members to try to be present to help reorient that person and for them to be supportive if the individual becomes frightened or distressed because he doesn't remember or understand what's happening. Major neurocognitive disorder is like a more severe, permanent case of delirium. For this disorder, there's evidence of major cognitive decline from the individual's prior level of functioning in at least one area of cognition. Changes in complex attention would mean that the individual cannot attend to multiple stimuli at once or multitask. Changes in executive function may be that the person has difficulty with planning or organizing. Changes in learning and memory include learning new information, keeping track of the plot of stories or TV shows, remembering short lists, or even remembering basic information or facts about oneself. Changes in perceptual motor skills involve difficulties knowing how to use certain objects, like a brush, or being able to tie one's shoes. And changes in social cognition indicate difficulties understanding others and social relationships. So these changes in functioning need to be based on two types of data. The first is that the individual, him or herself, reports these changes, or that someone knowledgeable of the individual's prior level of functioning, such as a family member, friend, or a clinician, reports it. The second is that this cognitive impairment is demonstrated through standardized neuropsychological assessments, similar to IQ testing, which will provide information on whether cognitive functions are lower than they should be for the person's age. Finally, this cognitive impairment must be so severe that it interferes with the person's ability to live independently and care for themselves, likely meaning that the individual needs to move in with family or be placed in a staffed residential home. There are several types of major neurocognitive disorders that vary depending on the cause. The most common type is Alzheimer's disease, which we'll discuss specifically in a few slides. So Alzheimer's is slow and progressively deteriorating course, and it ends up terminating in death. So typically it begins with memory loss for recent events, and then it progresses to disorientation, poor judgment, and inability to care for oneself. Importantly, Alzheimer's lowers resistance to disease, and so most of the time individuals often die from pneumonia or a cardiac problem. So typically the first symptom that's reported in individuals with Alzheimer's is memory loss for recent events. So things like they can't remember where they put their car keys, or they don't remember exactly what they had for breakfast. These problems with memory progressively get worse and more severe until the person loses memories for many basic facts about themselves. For example, a friend of mine had a family member who had Alzheimer's, and her first symptoms were that she would constantly retell stories. Even though everyone had heard these stories tons of times, she would repeat them over and over. Her memory problems then got a little worse, included things like not remembering if she had fed her cat. So she would end up constantly feeding the cat, resulting in the cat becoming very overweight. A more problematic issue was that she would forget if she took her medications. So some days she might not take any of her meds, and others she may take double or triple the dosage. It was around that time that everyone realized that she wasn't safe to care for herself anymore, and she needed to be moved into a residential home. As her memory impairment got worse, she started having difficulty remembering who certain people were, and ultimately was only able to recognize just a few of her family members. Alongside these memory problems, more severe Alzheimer's includes disorientation and poor judgment. So many people may not recognize or remember where they are, which tends to be very frightening for them. So that my friend's family member that I was just referring to was often not oriented to time. So she would talk as though she was a teenager again, and it was several decades ago. With regard to judgment, some individuals with Alzheimer's may lash out at others, becoming paranoid that they are trying to harm them. Or they may solicit others for sexual acts. Their impulse control and inhibitory responses have just completely diminished. As I mentioned, Alzheimer's ultimately culminates in death. This is because Alzheimer's lowers one's resistance to disease. So it's actually most likely that people will catch some illness like pneumonia and pass away from that. First, I want to make sure that the differences between delirium and major neurocognitive disorder are really clear. Delirium comes on quickly, has fluctuating symptoms throughout the day, and is typically temporary. Major neurocognitive disorder comes on slowly, the symptoms are stable, and the symptoms are also permanent. A quick note about the stability of symptoms. There's a term called sundowning that often is seen in people with major neurocognitive disorder, and this refers to a decline in functioning in the evening. This is thought to be due to the strain and fatigue of the day, such that the limited cognitive resources that the person has are simply taxed by the end of the day, which makes their symptoms appear worse. Evidence of the sundowning effect is not inconsistent with the supposed stability of symptoms seen in major neurocognitive disorder, as its patterns is reliable and it has a sensible explanation. This is different from what we see in delirium, where at any time of the day, the severity of symptoms can shift, and it's not a reliable pattern. Additionally, people with delirium can function for some period of time at a typical level before retreating into a declined cognitive state again. We will not see people with major neurocognitive disorder be able to function at prior cognitive levels, even temporarily. Diagnosing Alzheimer's can be difficult because there's no sure way to do it unless you autopsy the brain. So while someone is alive, it is diagnosed by ruling out all other possibilities for their symptoms. In autopsy, Alzheimer's can be confirmed in 3 ways. First, their brain will have substantial atrophy or shrinkage. Additionally, their brain will have a large number of amyloid plaques, which are protein deposits, and neurofibrillary tangles, which are fragments of collapsed neurons. Both of these are associated with neuron death, which is why the person experiences substantial cognitive dysfunction, since neurons are necessary for communication regarding the brain. Their presence inhibits the brain's ability to adequately communicate and process information, and it also interferes with the body's ability to resist minor infections. In these pictures, you can see what would be examined during autopsy. On the picture on the left, the circular shapes are plaques, and the spherical shapes are tangles. All brains will have some number of plaques and tangles in it, but not very many. So when we see an abundance of them, as this picture illustrates, is indicative of Alzheimer's. The picture on the right shows a comparison between the brain volume of someone with Alzheimer's and someone not with Alzheimer's. You can clearly see that a substantial amount of brain matter has atrophied for the person with Alzheimer's. To date, there's no cure for Alzheimer's. At best, medication can lengthen the time that a person has before they become severely impaired, but they will still eventually become severely impaired. Medication like Reminol and Aricept will delay the progression of cognitive deterioration for a few years and may actually improve some symptoms somewhat, meaning putting them back to where they were maybe about 6 months ago. But again, they're going to still continue to decline. You can see the benefit of taking medication from this graph. The purple line indicates people who take medication, and the red line indicates people who don't. People who take medication have about 3 or 4 more good years than people who do not take medication before they become severely impaired. So medication is recommended because it can add to the length of time that the individual can lead a better life. However, the medication has some negative side effects like nausea and pretty serious liver damage. So it should only be used when a diagnosis of Alzheimer's is as certain as possible. We wouldn't want to unduly cause serious damage to the liver in someone who didn't actually have Alzheimer's. Additionally, if people stop taking the medication, they actually will very quickly lose their gains. Next, we'll discuss sleep disorders. They are divided into the dysomnias, which include difficulties getting enough restful sleep, and parasomnias, which are abnormal behavior that occur during sleep. Remember, paraphilia means abnormal attraction, so parasomnia means abnormal sleep behavior. I want to also briefly discuss the sleep stages, since I'll be referring to these stages as we talk about the different sleep disorders. When we first fall asleep, we enter stage 1 sleep, which is very light sleep. During this sleep, our body is still slowing down, so our eyes are still moving very slowly and our muscle activity slows. We can be awakened very easily in this stage of sleep. There's another misnomer about sleep that we only dream in REM sleep. That is not true. Our dreams are qualitatively different in REM sleep than in other stages, which I'll discuss in a minute, but we still dream in all stages. While in stage 1 sleep, we are very likely to experience muscle contractions and sensations of falling, which often can coincide with vague dreams of falling. This happens to me a lot. I will jerk myself awake shortly after falling asleep while I'm in stage 1 sleep, often because I am dreaming that I am falling down or tripping. We then move into stage 2 sleep, where we are still in light sleep, but our eyes have completely stopped moving and our muscles are very relaxed. From there, we move into stage 3 and then stage 4 sleep, which is deep sleep where it is very difficult to wake us up. If you've ever been woken up and you feel extremely groggy and it takes you a minute or two to feel alert, you were likely awoken from stage 3 or 4 sleep. We spend a lot of time in stages 3 and 4 sleep in the first half of the night. After we enter stage 4 sleep, we start progressing back down the stages. So we go back into stage 3 and then stage 2. However, instead of going into stage 1, we enter REM. REM stands for rapid eye movement because in this stage, our eyes start rapidly moving. Our brain and physiological functions are very active during this stage, meaning that we see variations in things like heart rate and respiratory rate. As I mentioned, we dream in all stages, but in REM, our dreams are very vivid and detailed and usually follow some storyline. In non-REM sleep, our dreams are very vague and often don't follow a set storyline. So if you woke up and can recall in some detail the dream you were having, you were likely just in REM sleep before you woke up. In REM sleep, our muscles are also virtually paralyzed. This is sort of a safety device so that we don't act out our dreams and hurt ourselves or others. We tend to spend a lot of time in REM sleep in the second half of the night. This is why people tend to remember more dreams when they wake up in the morning than when they wake up in the middle of the night. After REM, a person starts progressing through the sleep cycle again, starting with stage 2. A person only ever enters stage 1 if they wake up and then fall back asleep again. We go through many cycles of sleep each night, and again, unless the person wakes up, the cycle through the stages in the following order: 1, 2, 3, 4, 3, 2, REM, 2, 3, 4, 3, 2, REM, and so on. The first sleep disorder we'll talk about is insomnia. I'm sure all of you have heard of insomnia and have a decent understanding of it, in that it refers to when people have difficulty sleeping. But it can be diagnosed under three specific circumstances: when the person has difficulty falling asleep at the beginning of the night, like laying in bed for 3 hours before finally falling asleep, or when they wake up much earlier than they want to and cannot fall back asleep, like waking up at 3 a.m. and just laying in bed until it's time to get up, or that they can fall asleep and generally sleep until they're ready to get up, but that they experience frequent awakenings throughout the night, which disrupts the sleep cycle and makes them feel as though they did not get a restful sleep. The degree of tiredness that these individuals feel during the day is either distressing to them and or it impairs their functioning. And this must occur at least 3 nights per week for at least 3 months. Many people experience insomnia, but it is more common among women. There are a variety of factors that can cause insomnia. It's associated with a variety of medical and psychological conditions. For instance, insomnia is a potential symptom in depression, PTSD, and other anxiety disorders. Stress and anxiety in general contribute to insomnia, often because the person is not relaxed enough to fall asleep or sustain sleep. Being too physically inactive can contribute to insomnia because a person's body may just not be tired enough to sleep much. Drug use and drug withdrawal can contribute to insomnia, depending on the type of drug used. Taking too many naps during the day can also make it difficult to sleep during the night. So there's this belief that some magic number exists of hours of sleep that everyone is supposed to get. However, this belief can actually cause and contribute to sleep problems. If you are very concerned about making sure that you get enough sleep, especially if you are worrying about it or ruminating about it and trying to force sleep too much, you will not be able to sleep. So that can also contribute to insomnia. Finally, many of our nighttime and bedtime behaviors can contribute to poor sleep hygiene, leading to insomnia. Doing things late at night, like exercising too late or eating too late, or especially drinking caffeine late at night, can make it difficult for us to sleep. More importantly, things that we do in our bed other than sleep have a huge impact on our ability to sleep, and this occurs through classical conditioning. It is recommended that the only things people should ever do in their bed are sleep and have sex. If you become used to sleeping in bed, you will associate your bed with being tired and sleeping, making it easy for you to fall asleep when you get in bed. However, many people do all sorts of other things in their bed, like read, watch TV, do work, or eat. These are all things that we do while we're awake. So the bed no longer is associated with being tired. Instead, it's associated with being awake. Through classical conditioning, this can lead to insomnia. There are medications that are often prescribed for insomnia, such as Ambien or Lunesta, but there are many problems with them. The first is that they are only actually supposed to be used for a short time, and not chronically like many people end up using them. When they are used for more than about 4 weeks, people can become dependent on them and experience tolerance, needing to use more of the medication to sleep, and they are likely to experience withdrawal symptoms, specifically in the form of rebound insomnia. Rebound insomnia occurs when a person has been taking a sleep medication for a long time, and they've been sleeping fine, so they stop taking the medication. However, because the person is now physiologically dependent on the medication, withdrawal occurs in the form of the reemergence of sleep problems. Now the person has insomnia again, and is perhaps even experiencing it worse than before. This leads people to think that they still have a sleep problem, even though in reality, this is just a short-term withdrawal effect that would go away in a few days. But because they don't realize that, they start taking the medication again, because clearly they must need it to sleep, and now they're on it for an even longer time. This is just a constant cycle that occurs for many people taking sleep medications. Therefore, sleep medications can actually end up hurting or making insomnia worse, and are not the best solution. Additionally, some of these medications, Ambien in particular, have some unusual and unwanted side effects. Some of you may have heard about the side effects of Ambien that people have experienced, such as doing weird things in the middle of the night and not remembering it, like eating or online shopping. There was even a court case where someone was claiming that she killed someone while on Ambien and didn't remember it. I can personally verify that Ambien does produce memory loss, and this memory loss could be very disturbing to some individuals, especially if they're experiencing it frequently. Luckily, there is an extremely effective psychological treatment for insomnia. The problem is that it's a difficult treatment, especially at first, to get people to agree to do and actually stick with. This treatment is called Brief Behavior Treatment for Insomnia, or BBTI. It's a brief treatment because large gains can be seen in only a few weeks. So treatment does not need to be long if the person follows the treatment guidelines. The person is asked to monitor their sleep for a week to get a good idea of the total hours of sleep they are actually getting on average. Let's say that someone goes to bed at midnight and gets up at 7, but they're only actually sleeping about 5 hours during that time. So since 5 hours is the amount of sleep they're getting, they are put on sleep restriction for 5 hours for the first week. This means that the person can only be in bed trying to sleep for 5 hours. They will need to choose what time they want to go to bed at and what time they need to get up at. So the person might choose going to bed at 12:30 and getting up at 5:30. The person cannot get into bed until 12:30, and they are instructed that if they are still awake 15 minutes later, to get out of bed. This is to break associations between being in bed and being awake. The person is then instructed to engage in some low-level activity in dim light, like washing dishes or reading, until they feel sleepy. Then they can get back in bed, and again, they have 15 minutes to get to sleep. Otherwise, they have to get out of bed again. The cycle continues until the person finally falls asleep. However, they still must get up at 5:30, even if they didn't actually fall asleep until 3 a.m. If they don't, this treatment won't work. But this is also why this treatment is so difficult. If the person decides instead to stay in bed until 9 or so, they'll have trouble getting to bed again the next night. Instead, if they get up at 5:30, hopefully by the time they should go to bed the next night, they'll be sleepy enough to just fall asleep. So the person does this until they can regularly sleep for the scheduled 5 hours. This will usually start happening quickly if the person is following the guidelines. Then sleep time is gradually lengthened by about a half an hour until the person gets to an adequate amount of sleep for them. Alongside all of this, the person is instructed to improve other sleep hygiene, such as not drinking caffeine late in the day or exercising too late. And their unrealistic expectations about things like needing to get 8 hours of sleep are challenged. Hypersomnolence disorder is diagnosed when the person feels extremely tired throughout the day, similarly to an insomnia, but despite the fact that they actually got an adequate amount of sleep, specifically at least 7 hours of sleep overnight. Despite this amount of sleep, they're either recurrently taking naps during the day, they sleep for at least 9 hours at night but still complain of feeling excessively tired, or upon awakening, it is extremely difficult for the person to feel fully awake, indicating that they're still spending a lot of time in deep sleep, which is symptomatic of not getting enough restorative sleep. This has the same time duration as insomnia, of needing to occur at least 3 times per week for 3 months, and causes distress or impairment in functioning because they feel so tired. Hypersomnolence disorder is thought to be inherited, though research has also found that people exposed to certain viral infections may also be at increased risk for this disorder. Treatment usually involves medication, often stimulant medication like Ritalin, or a wakefulness agent called modafinil. Narcolepsy is a really interesting disorder. In this disorder, people periodically throughout the day feel the irresistible urge to fall asleep, and many of the times they will actually just pass out, regardless of what they've been doing. This needs to occur again at least 3 times per week for 3 months. Alongside this, they experience cataplexy, which means that they experience a sudden loss of muscle tone. This could be minor in that the person feels weakness in their facial or arm muscles, or it could be more severe in that the person's body just collapses. The reason that this happens is because when people with narcolepsy fall asleep during these irresistible urges to sleep, they bypass all of the other stages of sleep and go directly into REM. In this disorder, they are constantly being pulled into REM sleep throughout the day. Remember, REM sleep is associated with muscle paralysis. So basically, people with narcolepsy experience sudden forms of muscle paralysis throughout the day, since their body is trying to pull them into REM sleep. This tends to happen during more emotional times when the person is very happy or very anxious or frightened, for example. Narcolepsy is rather rare and occurs equally among both genders. It tends to start fairly early in life, around adolescence. Additionally, when people either fall asleep or come out of a sleep during a narcoleptic episode, they're likely to experience either sleep paralysis, where they are awake but cannot move any of their muscles because their body is still in part of REM sleep, or they experience hypnagogic hallucinations, which occur while the person is falling asleep, or hypnopompic hallucinations, which occur when the person is waking up. These hallucinations are incredibly vivid experiences that are said to be unbelievably realistic because they include visual aspects, but also other sensory experiences like touch, hearing, and sensation of body movement. The reason behind these hallucinations and the sleep paralysis is that REM sleep, including dreams and muscle paralysis, is bleeding over into the person's waking life. This can be a really scary experience for people who are feeling like they are experiencing really vivid, dreamlike hallucinations and yet are paralyzed and cannot get away from it. So I'll post the link to this video, and it's about narcolepsy. This video depicts it in a dog, not a human, but you can still get a sense of how disruptive this disorder can be. Narcolepsy is passed along genetically and is a recessive trait, which is why it's rare. Both of your parents would need to be carriers of narcolepsy for you to have it. Similarly to hypothalamic disorder, it's also thought that exposure to certain infections earlier on in life may trigger autoimmune problems, resulting in narcolepsy. For treatment, modafinil, which is a wakefulness agent, is often used to keep the person awake. SSRIs are also often used because they decrease the amount of REM sleep that we have, making it less likely that the body will continue to pull the person into REM sleep. The last of the dysomnias are the breathing-related sleep disorders, which occur when people experience sleep disruptions because their ability to breathe at night is restricted. People with these disorders tend to feel very tired throughout the day, and the reason for this is that they are being woken up frequently throughout the night because of their difficulties breathing. Some individuals with these disorders don't even realize that it's happening though. They only know that they're very tired during the day. It's not until a spouse or partner tells them that they notice that they stop breathing or have difficulty breathing at night that they realize that that's the culprit behind them not getting sufficient sleep. There are 3 different types of breathing-related sleep disorders that we'll discuss. Apneas refer to when people actually stop breathing for some period of time, while hypoventilation results when the person continues breathing, but their breathing is very shallow and labored. In obstructive sleep apnea, the person completely stops breathing for at least 10 seconds at a time. In this case, airflow stops despite continued activity by the respiratory system in the brain. So either their airway may be too narrow or some abnormality or damage interferes with their effort to breathe or compresses the airway. For the diagnosis, the person must undergo polysomnography, meaning a medical sleep study, and there must be evidence of at least 5 obstructive apneas per hour that includes either nocturnal breathing disturbances like snoring or snorting, or the person must report excessive daytime sleepiness. Or the person needs to experience at least 15 apneas per hour of sleep. Snoring is typically a hallmark of obstructive sleep apnea, and this type of sleep apnea is most commonly found in individuals who are overweight. In central sleep apnea, again, the person is experiencing a disruption and halt in airflow, specifically at least 5 per hour of sleep. But the reason is different. In this case, there is a complete cessation of respiratory activity in the brain. So the person stops breathing because the brain is no longer telling the person to continue breathing. This type of sleep apnea is most commonly found in people with certain central nervous system disorders like head trauma or vascular disease. Finally, in sleep-related hypoventilation, the individual continues breathing, but polysomnography indicates that there are episodes throughout the night of shallow breathing that are associated with elevated carbon dioxide levels, indicating that the person is not getting enough oxygen. Obstructive sleep apnea and hypoventilation are often caused by being overweight. The airway becomes constricted and at times even blocked by fat deposits around the upper airway or because a thick neck may actually narrow the airway. Central sleep apnea is often the result of different medical disorders affecting the central nervous system. So for treatment, weight loss may be an effective method for those with obstructive sleep apnea and hypoventilation. Otherwise, a CPAP machine is often prescribed, and that's what you can see in this picture here. CPAP stands for continuous positive airway pressure because it continuously forces air through this mask that you wear on your face, and that air pressure keeps the airway open. However, can you think of some downsides to this treatment? For example, Could you imagine sleeping comfortably with that large mask over your face? Adherence to this treatment is the biggest downside because people are uncomfortable or may feel claustrophobic while wearing this mask. Moving into the parasomnias, non-rapid eye movement sleep arousal disorder is the first disorder that we'll discuss. This disorder is most commonly observed in children. So for this diagnosis, the kid recurrently wakes up, but the waking is incomplete, indicating that the person does not obtain full conscious alert arousal. This awakening generally occurs in the first third of the sleep cycle. As I mentioned before, during the first half of the night, the person is likely to be spending most of their time in stages 3 or 4 sleep. So for this disorder, the person is waking during deep sleep. I'll come back to that point in a minute. Additionally, during this incomplete wakening, one of two things happens. Either the person engages in sleepwalking behavior, where the person gets up out of bed and moves around, typically with a blank staring face and unresponsiveness to the efforts of others to communicate, or the person has a sleep terror, which typically involves a panicky scream and intense fear and signs of automatic arousal like rapid breathing, sweating, and racing heart. During sleep terrors, the child is typically unresponsive to the efforts of others to comfort him, and if asked about what he was dreaming about, the child is frequently unable to verbalize exactly what it was that he was dreaming about, except for maybe being able to say that it was a monster or something scary. This is because, as I mentioned before, the child was in deep sleep and not in REM, so there is not a vivid storyline accompanying the dream. Similarly, when someone who was sleepwalking is asked what they were dreaming about, they're not able to recount any type of vivid dream. Again, because they were not in REM sleep. If they were in REM sleep, they would not be able to get up and sleepwalk anyway, since their muscles would be virtually paralyzed. After the person has fully woken up, they typically have little memory of sleepwalking or of the night terror. However, these frequent awakenings cause the child distress or impairment. The treatment for this disorder is something called scheduled awakenings. Generally, when people have night terrors or sleepwalk, they tend to do it around the same time each night, at the same point in their sleep cycle. So the parents are instructed to wake the child up about 20 or 30 minutes before the occurrence usually happens. This resets the child's sleep cycle and makes it less likely that this behavior will occur. After a few weeks of having their sleep cycle reset, the parents can gradually cut back on waking the child up, and the symptoms tend to disappear. On another note, there's also a myth that it is dangerous to wake someone while sleepwalking, and I want to dispel that. It is not at all dangerous to do so, and in fact, it's recommended that you do wake someone who is sleepwalking because they could harm themselves or others while sleepwalking. Finally, we have nightmare disorder. This disorder occurs when someone repeatedly wakes up in the night due to the experience of vivid and detailed frightening dreams, usually involving threats to one's survival, security, or self-esteem. These awakenings generally occur in the second half of the sleep period, when they are more likely to be in REM sleep. Remember, we only have really vivid dreams that follow a storyline during REM sleep, so nightmares occur during REM. When people wake up from nightmares, they are immediately oriented and alert. They recognize that they're no longer in their nightmare, and they know they are awake and safe. This is in contrast to people with sleep terrors, who are not immediately alert and oriented upon their incomplete awakening. Again, these repeated nightmares cause the person distress or impairment in functioning. The treatment for nightmare disorder is something called image rehearsal therapy. In this case, the person is asked to recall and write down in detail their nightmare, but to change up the theme, storyline, ending, or any part of it to convey a more positive tone. Then the individual is instructed to rehearse and imagine the rewritten dream scenario for about 10 to 20 minutes per day while awake. This serves to inhibit the original nightmare, providing a cognitive shift that refutes the original premise and displaces the unwanted content when that dream starts to reoccur. Lastly, we'll discuss substance use disorders. These disorders all involve the continued use of a psychoactive substance, despite that substance causing the individual significant problems. The name of the specific diagnosis an individual would receive depends on what substance they are using and experiencing related problems from, though the criteria will all be the same. So someone might be diagnosed with alcohol use disorder, or with stimulant use disorder, or with opioid use disorder. Each of these people likely have similar problems to one another, It's just that different drugs are causing those problems. There are 11 possible symptoms for a substance use disorder, and an individual actually only needs to report 2 of them occurring within the same 12-month period. This isn't to say that these symptoms need to be present for an entire 12 months. They only need to both be present at some point within the same 12-month period. So the first criterion is that the drug is taken in larger amounts than intended or over a longer period of time than intended. It's important to note the intention piece here. So just simply using a lot of the drug is not sufficient to meet this criterion, as long as the person intended to do so. So if I always drink 8 beers every day, but that's my plan or intention, I do not meet this criterion. Instead, this criterion is assessing loss of control. So I would meet this criterion if I intended to only have 1 or 2 drinks, but recurrently I would end up drinking many more than that. Or if I intended to just meet up with friends at a bar for 1 hour, but I always find myself ending up staying out and drinking all night long. The next criterion is related to difficulty cutting down or quitting. So this is only relevant to people who have tried to quit or who spend a lot of time worrying about their use and thinking about quitting. If someone has never even thought about quitting, they wouldn't meet this criterion. Instead, someone meets this criterion when they have tried to cut back or stop using several times, and each time they'll fail and resume using. Or if they recurrently think about and desire to cut back, though they may find it too difficult to actually make the quit attempt. The third criterion is that the individual spends a lot of time engaged in attempts to obtain the drug or recover from the drug. So a person would meet this criterion if they have to spend a lot of time tracking down their drug dealer or finding where to get the drug, or even needing to engage in prostitution or theft to obtain the drug. Or they could meet this criterion after using the drug, it takes them a really long time to recover, such that they cannot engage in other meaningful parts of their life. The fourth criterion is largely based on subjective report. A person meets this criterion if they report a strong urge or craving to use. The fifth criterion is that the person's drug use results in them failing to fulfill major role obligations in their life. So they recurrently miss work or show up late or hungover, or they miss class and never complete assignments or study for tests, or they are unable to effectively care for their house or children. The sixth criterion is met when their drug use causes interpersonal or relationship problems, and the individual continues using anyway. So for example, a man who consistently gets into fights with his friends or with his girlfriend when he drinks, which causes strain on these relationships. He continues drinking anyway. The seventh criterion is that the person stops engaging in important social, occupational, or recreational activities because he would rather use. So for example, someone used to like going to movies with friends, playing sports, and spending time with coworkers. But he has just completely stopped doing this because the time he used to spend engaged in these activities is now preferentially spent using the drug. The eighth criterion is that the individual recurrently uses the drug in situations where it might be physically hazardous. The most common example here is driving while intoxicated, but it could also include operating heavy machinery while intoxicated, or even walking home alone at night in a sketchy part of town while intoxicated. The ninth criterion is that the individual experiences physical or psychological problems stemming from their use, and they are aware of this, but they keep using anyway. So it's not just that they have these problems, it's that they don't stop using in response to developing these problems. So this would be someone who maybe has become extremely depressed from their heavy alcohol use, but that doesn't stop them from drinking. Or someone who develops emphysema from smoking cigarettes, but they keep smoking anyway. The 10th criterion is that the person experiences tolerance. What's meant by tolerance is that the individual no longer experiences the same effects that he did when he first started using. So he needs to start using more to achieve that same effect. So an example is someone who used to consistently feel pretty drunk after drinking about 3 beers, but now has to drink about 6 to achieve that same effect. Finally, the last criterion is withdrawal. Withdrawal symptoms vary by drug. Each drug class is associated with its own specific type of withdrawal syndrome, but they include negative physical and psychological symptoms. For example, opioid withdrawal includes flu-like symptoms. Alcohol withdrawal can include tremors, seizures, and physiological hyperarousal. and marijuana withdrawal includes irritability and sleep difficulties. Substance use disorders are always diagnosed with a severity specifier. A person meets criteria for the disorder just by having 2 symptoms within the same 12-month period. A person who only meets 2 or 3 criteria is considered to have a mild substance use disorder. Probably many of you know at least one college student who meets criteria for mild alcohol use disorder. It's a fairly easy disorder to meet criteria for in the college years. However, severe substance use disorders require at least 6 of the criteria to be met, and these are the people whom we would be most likely to consider addicts. Gambling disorder is another disorder included in the addictive disorders category of the DSM. You'll notice that the symptoms overlap quite a bit with those of substance use disorder. For this disorder, the person must experience persistent and recurrent problematic gambling behavior as indicated by at least 4 symptoms within the same 12-month period. The first criterion is that the individual needs to gamble with increasing amounts of money to achieve his desired excitement. Hopefully you can recognize that this is the equivalent to the tolerance criterion from substance use disorders. The second criterion is that the individual feels restless or irritable when they cut down or stop gambling. This is the equivalent of withdrawal. Third, the person has made repeated unsuccessful attempts to stop or cut down on gambling, which is very similar to one of the substance use disorder criteria. The fourth symptom is that the individual is often preoccupied with gambling. This is most equivalent to the craving or desire to use drugs criterion for substance use disorders, and in this case, consists of persistent thoughts of reliving past gambling experiences, planning their next gambling venture, or thinking of ways to get money with which to gamble. The next symptom is that the individual often gambles when feeling distressed, which is getting at negative reinforcement motives. The sixth symptom is that the individual continues coming back to gamble in order to get their money back after a loss. This helps explain why the person continues to keep gambling, even after losses and other negative consequences. The seventh symptom is that the person will lie to conceal their gambling behavior. So a man might tell his wife he's going out with friends or working, and instead he goes gambling. Or he might make up excuses for where the family's lost money went. The eighth criterion is that the individual has jeopardized or lost an interpersonal relationship, a job, or a career opportunity because of their gambling. So examples here could be that his wife or partner left him because of his gambling behavior, or he was fired from work because he was gambling while he should have been working. The last criterion is that the individual ends up relying on others to loan him money to alleviate some desperate financial situations caused by his gambling. Because of the excessive gambling behavior, the person may have gotten himself into serious debt and starts looking to others to help him out financially. Similarly to substance use disorder, gambling disorder is also diagnosed with a severity specifier. 4 or 5 symptoms indicates a mild disorder, while the disorder is severe when the individual meets nearly all of the criteria. Substance use disorders are generally more common among men and are associated with a variety of problems, specifically with regard to physical, psychological, and societal consequences. People experience a lot of health-related problems resultant from drug use and may die either from these problems, acute intoxication, or withdrawal in some cases. Chronic substance use is often associated with many mood and anxiety disorders. They are also an economic burden to society with regard to things like prevention and treatment efforts, healthcare costs, and homelessness. There are a variety of factors involved in the etiology of substance use disorders, and I'm only going to cover a few in this lecture. With regard to genetics, alcohol use disorder specifically tends to run in families. There appear to be a few important physiological reactions to alcohol that are inherited. The first is related to the metabolism of alcohol. Some people inherit a faster metabolism of alcohol, making it so that they feel less drunk compared to people drinking the same amount. This may allow them to increase their levels of drinking to amounts that may be more likely to become problematic. People may also inherit a low subjective response to alcohol, such that they just don't experience alcohol's effects as strongly as others. Again, this may be associated with the tendency to drink more in order to experience the wanted effects. Finally, some people, especially those of Asian descent, may inherit an alcohol flush reaction, where they experience an unpleasant physiological response when they drink alcohol, including feeling nauseous and developing a red or flushed face. It's thought that this inherited reaction is protective against use, since the person feels sick and uncomfortable when they drink. Neurotransmitters are likely involved as well, specifically dopamine. Dopamine is a hormone associated with reward, so it could be that people with substance use disorders have an overactive dopamine system, leading them to seek out pleasurable drug-related experiences more often. With regard to psychological etiological factors, learning experiences definitely play a role. Both positive and negative reinforcement are involved in substance use. For example, we might use drugs to feel good, which is positive, or we might use drugs to alleviate negative mood, which is negative. Vicarious learning also plays a role. We are more likely to initiate drug use if we have seen other people use drugs and have positive experiences. Finally, expectancy effects also influence substance use. Expectancy effects are consequence-oriented beliefs about drug-related outcomes. These can be positive or negative. So, for example, I can expect alcohol to make me sociable and have fun, or I can expect alcohol to make me aggressive and anxious. If I hold a lot of positive expectancies and few negative expectancies, I'll probably be more likely to use that drug. It tends to be difficult to treat substance users, and they often experience several failed quit attempts. At least part of this is because of the refusal to acknowledge that their use is problematic, and many people don't have strong motivation to change, or at least the reasons to continue drinking outweigh the reasons to stop drinking. There are several medication options that are available to help people stop using various drugs. If a heavy alcohol user wants to stop using, he will likely need to be medically monitored and provided with detoxification assistance, because without that, withdrawal symptoms could be fatal. So medication is used during detoxification to keep the person safe. Detox includes administering benzodiazepines to decrease potentially dangerous physiological arousal, and anticonvulsants may be administered to prevent seizures. Aversive treatment, such as Antabuse, works on classical conditioning principles to make drinking alcohol associated with unpleasant consequences. When someone takes Antabuse and they drink alcohol, they will vomit, thus making vomiting associated with alcohol. The problem with this treatment is that not many people voluntarily want to take this medication, and if they just want to drink one day, they simply don't take the Antabuse that day. It's only effective if it's taken regularly. So it's best used temporarily while the person is also receiving psychological treatment. Additionally, Antabuse doesn't work well for some people because many people who drink heavily expect negative consequences already. So vomiting is not unexpected or negative enough to influence their drinking. Another medication option is antagonist treatment. Remember, antagonists block or decrease the amount of neurotransmitter available, which means that the effects of the drug will be decreased. So drugs like naltrexone and acamprostate decrease craving for alcohol and decrease the subjective effects of alcohol. Zyban or Wellbutrin is used to help people stop smoking by also decreasing craving. Finally, there are agonist treatments, which are also known as drug substitution treatments. In these cases, the individual uses a medication that provides the person with many of the same physiological effects as their drug, but in a safer way. For example, methadone or buprenorphine are used in substitution of opioids like heroin. They will produce many of the same physical effects, so the person doesn't experience withdrawal symptoms, but without as much euphoria and in a safer way, as the individual doesn't need to engage in unsafe behaviors like prostitution or theft to access the drug, and they won't be sharing needles. The nicotine patch or gum works in the same way. Nicotine is still delivered to the body, though at a lower dose and in a safer way, so that the individual's risk of lung or pulmonary problems is decreased. For psychological treatment, CBT is the most common treatment administered by psychologists. CBT includes educating patients about the consequences of their substance use and the cycle of addiction, and then spending a lot of time teaching people coping skills to use to cut down and refrain from use, including things like getting rid of all of the alcohol in the house and finding other activities to do when they would typically be using. This will also include modifying expectancies to attempt to strengthen their negative expectancies and weaken their positive ones, which should make it easier for the person to stop using. The therapist and the patient may practice being exposed to drugs or cues that are related to drugs for the patient, thus, giving the patient practice dealing with those situations without using. Finally, a lot of time is spent on relapse prevention to try to decrease the chances that the person will start using again. This may include discussing even simple or seemingly irrelevant decisions, like the route the person usually takes home from work, and if that includes a bar, perhaps you should find a new route. 12-step therapies like Alcoholics Anonymous or Narcotics Anonymous are another treatment option. AA is not conducted by psychologists. Instead, the groups are run by former alcoholics. They are based on the assumption that alcoholism is a disease, meaning that it needs to be managed daily for the rest of one's life. Just as someone with diabetes needs to monitor their insulin levels on a daily basis for the rest of their life, someone with an alcohol use disorder needs to spend each day working on maintaining their abstinence for the rest of their life. Drinking is never allowed. Many psychologists practicing CBT take an abstinent approach as well, though others, depending on the patient, may take a harm reduction approach where the person may eventually be able to drink a little, but without the associated problems. In AA, the person is taught to turn over their life to a higher power, which usually means God or some other religious or spiritual persona. Thus, many people who are not religious or spiritual may have a difficult time fully engaging in AA. However, others are able to find a non-religious higher power to turn their life over to. Because substance use disorders are viewed as a disease, personal responsibility is lifted, because it's not their fault that they have the disease, just as it would not be a person's fault if they had type 1 diabetes. However, the person is taught that it is their responsibility to make sure they change their behavior and do everything they can to take care of their disease. These 12-step treatments are conducted in groups, so there's a strong emphasis on social support and having a network of individuals who have a range of experiences trying to stop using that can be helpful to newer members. The remaining slides include the What's the Disorder activity. As usual, please let me know if you have any questions or would like to check your answers with me. Here's the first one. Bonnie was placed on a new medication. Shortly thereafter, she became very disoriented and didn't know where she was. She had trouble recognizing her family members or remembering what was said to her. These symptoms fluctuated throughout the day, such that at times she appeared fairly clear and lucid, and at others, she couldn't stay focused on even simple tasks and appeared to have no memory of what she had done just 10 minutes ago. These symptoms cleared up after her medication was discontinued. Tamara has been feeling extremely tired for the last several months. She saw a doctor who encouraged her to undergo a sleep study. The results of the study demonstrated that Tamara has several instances during the night where her breathing becomes very restricted and shallow. The doctor stated that she is not getting sufficient oxygen while sleeping and instead has an excess of carbon dioxide in her blood. At several points throughout the day, Paul feels extremely sleepy and will often suddenly fall asleep, even while in inappropriate places. He feels that he does not have control over these sleep episodes. Upon falling asleep, he immediately experiences vivid dreams. Upon waking, he sometimes is completely unable to speak or move any of his muscles. At some points during the day, especially when he is laughing and joking with others, he also experiences muscle weakness, particularly in his arm and facial muscles. This causes him to drop things or to slur his speech. This has been occurring nearly daily for the last year. Joey spends his entire weekends at the casino. He spends his days at work thinking about the weekend and gambling. He often tells his wife that he is working overtime during the weekends because she has recently become upset that he's losing so much money. Joey took out a loan from one of his business partners because he lost so much money and didn't want to tell his wife about it. He has tried to refrain from gambling, but he becomes irritable and feels like he's driven to go to the casino. He can't stop. Mary goes to bed at 10 p.m. every night and wakes up at 3 a.m. She is unable to fall back asleep and lies there until she finally gets out of bed at 6 a.m. This has been happening for the past year, and it has affected her performance at work because she feels so tired all of the time. Carl's wife recently insisted that he see a doctor because she noticed that he stops breathing in the middle of the night. According to Carl's wife, he has always snored very loudly. But recently, she's noticed periods of time when he suddenly stops snoring and instead makes gasping noises, as if he's trying to breathe but he is unable. She listened to hear if he was breathing and found that he seemed to stop breathing for about 20 seconds, upon which time Carl woke up. Carl wakes up every time he stops breathing, though this disrupts his sleep and he feels extremely tired during the day. A sleep study confirmed that this occurs several times per night. Cody frequently wakes his parents up at night because he lets out a loud scream. When they go to check on him, he is often sitting up in bed shaking and sweating. Cody never has any memories of this the next morning and cannot remember what he has been dreaming about. Dexter uses cocaine every weekend. He states that he could stop using if he wanted to, though he does report that by the time the work week comes to an end, he experiences a strong craving for cocaine. He frequently uses more cocaine than he intended to use, and more often than not, he is unable to take care of the errands he meant to do over the weekend because he's recovering from his cocaine binges. Over the past 3 years, Denise's family has noticed a gradual decline in her cognitive abilities. She began having trouble remembering where she put items in her house, and this gradually evolved in difficulty remembering what she had done during the day, repeating stories she had just told, and forgetting some people in her extended family. Recently, her family has noticed that she has a very difficult time remembering the names of objects, and at times, even recognizing them. Denise's cognitive decline was verified by cognitive testing. This greatly upsets Denise because she is unable to live alone anymore, and she can't understand why she is having such a hard time with her memory. Every day, June takes a 3-hour nap in the afternoon. She feels so exhausted throughout the day that she cannot function without this long nap. She also sleeps approximately 9 hours per night. June has not been working for the past year since this feeling of excessive exhaustion began. Carly wakes up nearly every night and runs into her parents' room to tell them about the scary dream she had. Usually her dream is about robbers coming into her house, though sometimes she also dreams about being surrounded by snakes. Upon awakening, Carly is completely oriented to her surroundings. Carly is able to recall vivid details from these dreams, and they are very upsetting to her. Tony had a sleep study conducted after his wife stated concern that she thought he might not be breathing at times during the night. The sleep study found that at several times during the night, Tony completely stops breathing. There appears to be no continued effort to breathe, and there is no chest movement for up to 45 seconds at a time.